you very much. So, okay. So I was telling that some of these advices that we should give the patients, they are in common with the previous recommendations for 0 to 3 years old children. And here it is good practice to use only a pea-sized amount. For 0 to 3, it is better to use a smear layer, just a smear layer amount of fluoridated toothpaste. But here we can use pea-sized amount. We will see a picture of the difference between these two. And parents and carers should do brushing. And here is another important recommendation that spit out after brushing and do not rinse to maintain fluoride concentration levels. This is something that many people in the comments, they do not know about that they should not rinse their mouth after toothbrushing. Just spit out and not rinsing to maximize the effect of fluoride. The frequency and amount of sugary food and drinks should be reduced, and sugar-free medicines should be recommended. There is a professional, because these sets were advised to be given. These were advised to be given to the parents or to the patient. But here, we are talking about professional intervention in our offices. Okay, so for this age group, we have fluoride varnish. We should apply fluoride varnish to teeth 2 times a year. 2.2% NAF minus. And you can see here the picture of fluoride varnish. And it is easy, it's easy to apply. I told you prevention procedures are easy to do. So this is a professional intervention that we should do for 3 to 6 year old children. Then we will go to children age 0 to 6, but those likely to develop caries, those with special needs. So those who are at greater risk of caries development. What should we do for this group of patients? Regarding the advice that should be given to the parents, in addition to all previous advices, we should recommend to use fluoridated toothpaste containing 1,350 to 1,500 ppm fluoride. So more concentration of fluoride is needed for this group of patients. And it is good practice to use only smear or pea-sized amount. We have these. Where medication is given frequently for long-term, request that is sugar-free or used to minimize cariogenic effects. And you can see here the difference between a smear layer and pea size. Here is the 19 millimeter to have some estimation of the size. And this is smear layer, this is smear amount of toothpaste, and this is pea sized blob of toothpaste. Okay. And then professional interventions for these special need patients, special need children from 0 to 6 years old. Fluoride varnish should be applied 2 times a year. We should reduce recall interval. So we should visit these patients more frequently. And then we should investigate diet and assist adoption of good dietary practice in line with Eat Well guide. We will have something about Eat Well guide in the next slides. And where medication is given, we should focus on sugar-free medications, like the previous advice that we had. Okay, this is a picture of my our last visit to the School of Dentistry of Kharkiv National Medical University, School of Dentistry. So students and staff members, as I told, we have very good memorials of this visit, just to change the taste and draw your attention. So we want to go to prevention of caries in children aged from 7 years and young adults. Okay, for this group of patients, again, we have some common recommendation like the other groups. So twice daily brushing, 1 at night, 1 during the day, using fluoridated toothpaste with this amount of fluoride. We should spit out. We should recommend the patient to spit out after brushing, not rinsing. And the frequency and amount of sugary food and drinks should be reduced. And the professional intervention here again is applying fluoride varnish to teeth 2 times a year. And for those who, those patients in this age group that they are at greater risk of developing caries, for example, those with obvious current active caries, those with ortho appliances, you know that in this age group, it's very common that they have ortho appliances, orthodontics appliances, or those who are suffering from dry mouth or other predisposing factors, and those with special needs. Then, in addition to all previous advices, we should advise to use a fluoride mouth rinse daily. NaF with this concentration, as you can see, at a different time to brushing. This is something that we should recommend these patients because of their higher risk of caries development. They should do this. And we have some professional interventions for this age group with these special need patients. So we should fissure seal permanent molars with resin sealant. This is a professional things that we, professional practice that we should do in our routine practice. We should apply fluoride varnish to teeth 2 or more times a year. Here, we should do it maybe according to the risk of the patient, maybe we should do it more times, more than 2 times a year. And for those 8 years upwards with active caries, we should prescribe daily fluoride rinse. And for those up to 10 years and up, we should, those with active caries, we should prescribe the 2,800 ppm fluoride. So toothpaste, the toothpaste with more concentration of fluoride. For those with more than 16 years old with active disease, we should prescribe even up to 5,000 ppm fluoride toothpaste. And we should investigate that and assist to adopt good dietary practice in line with its guide. Okay, and just again, something different. Do you know what is the origin of the word hygiene? Maybe you have heard about Asclepius. He's a hero and god of medicine in ancient Greek religion and mythology. And one of his daughters is Hygiene. And it is said that one day, Hygiene came to her dad and said, why instead of just treating the patient, why don't you think about prevention? So Hygiene is the goddess of cleanliness in ancient Greek mythology. And the word hygiene comes from her name. So just something about the origin of the word oral hygiene and hygiene. Now we want to come to prevention of periodontal disease to be used in addition to caries prevention, because we know that our topic is prevention in children and adolescents. So the main disease, oral disease in these age groups is dental caries. And at the same time, we may have some problems with periodontal disease. So we should also think about periodontal diseases. So in periodontal diseases, this is for all adults and children. So not confined to children, but all adults and children, we should try to have some self-care plaque removal. Remove plaque effectively using methods shown by the dental team. This is the advices that we should give to the patients. This will prevent gingivitis, gum bleeding, or redness, and reduces the risk of periodontal disease. Daily effective plaque removal is more important to periodontal health than tooth scaling and polishing by the clinical team. And I will have a shocking news regarding this in the next slides. I will tell you. Brush gum line and each tooth twice daily before bed and at least on one other occasion. We have this. And use either manual or power toothbrush. No difference. Sometimes, and for some patients, maybe power toothbrush works better, but no difference. And then a small toothbrush head and medium texture should be used. And we have this professional intervention for all adults and children regarding periodontal health. So advise best methods for plaque removal to prevent gingivitis and achieve lower risk of periodontitis and tooth loss, we should use behavior factors which impede effective plaque control, including, for example, supra and subgingival calculus. So if there is any supra and subgingival calculus, they should be removed first because they prevent the patients to do effective plaque removal. We should open mark removal. With extensive inflammation, start with toothbrushing advice, followed by interdental plaque control. If there is extensive inflammation, we should start with toothbrushing advice, and then we should go to interdental plaque control. And then assess patients and parents' carers' preference for plaque control, decide on manual or power toothbrush, demonstrate methods and types of brush, test plaque removal abilities and confidence with brush, and patient sets targets for toothbrushing for next visit. For all adults and for those between the ages 12 and 17, we should have this advice as well. Interdental plaque control, clean daily between the teeth to below the gum line before toothbrushing. For smaller spaces between teeth, we should use dental floss or tape. And for larger spaces, we should use interdental or single tufted brushes. And around orthodontic appliances, because many patients in this age group, they have these orthodontic appliances. And also bridges. We should use kits suggested by the dental profession. These are the advice that should be given to the patients. And the professional intervention here is to assess patients' preference for interdental plaque control, decide on appropriate interdental kit, demonstrate methods and types of kit, and assess plaque removal abilities and confidence with kit. Patients set target for interdental plaque control. And this is the shocking news that I told you. This is just recently published article. You can see the title, Examining the Impact of Oral Hygiene Advice and for Sale and Polish on Periodontal Diseases. And this is a randomized controlled trial published in British Dental Journal in 2021. And you can see here the conclusion. The conclusion is something new for us. Results suggested that scaling and root planning treatments and delivering brief personalized OHI provide no clinical benefit and are therefore an inefficient approach to improving dental health. However, the general population value both interventions. You can see here brief personalized oral health, OHA, oral hygiene advice, okay? But if we go deep and we try to do some behavior change, it will certainly work. But the shocking thing is that scaling and root planning treatments may result in no benefit for patients. And again, this finding tells us that the patient has the responsibility to maintain periodontal health. This is not the responsibility of the dentist. Then we want to go to risk factor control. We know that tobacco is one of the risk factors for periodontal diseases. So for all adults and adolescents, we should advise the patients do not smoke, because smoking increases the risk of periodontal disease, reduces benefits of treatment, and increases the chance of losing teeth. There are models and protocols for dentists and health professionals to apply in their routine practice. One of the models is this 3A, ask, advise, and act. This is, I think, this has many details and it's not possible to focus on it now. We have separate workshops for our undergraduate students to teach them how to use these models in their clinical practice to do smoking cessation consultation and activities in their offices. We should do this. This is one of the professional duties of the dentists. And we know that diabetes is also another major risk factor for periodontal disease. Patients with diabetes should try to maintain good diabetes control, as they are at greater risk of developing serious periodontal disease and less likely to benefit from periodontal treatment if diabetes is not successful. And we have some professional intervention here. We should explain risk-related diabetes. We should, for patients with diabetes, we should explain risk related to diabetes. And regarding the medications, some medications can affect gingival health. We know that. We should be aware of that. We should recommend patients about that. And regarding professional intervention, we should be, for patients who use medications that cause dry mouth or gingival enlargement, we should explain oral health findings and risks related to medication and assess and discuss clinical management. Okay, this is something. Let's do some calculations. Can you tell me what is the population of Ukraine? Of course, I cannot see the chat box, but
there is no message.
Sorry?
No message in the chat.
No message. Okay, thank you.
No message.
So who can say that? What is the population of Ukraine? Do you have any estimation? As I know, it is about 45 million. 45 million. But how many dentists are currently working in Ukraine? Do you know? Is there any idea? Because I don't know this one. How many dentists are currently working in Ukraine? Just some rough estimations. We don't want exact number. Just rough estimation. For example, 2,000, 10,000, 20,000, something like that. If there is any estimation. Okay, so just do this exercise for yourselves. How many days, months, or years does it take that the dentists cover all treatment needs of the population? For example, I don't know, if we have 10,000 dentists working currently in Ukraine, and we have these 45 million people, how many years does it take that these 10,000 dentists can cover all the treatment needs of these 45 million population? You can calculate it. But do you know what is the true answer? What do you guess about the true answer of this question?
Okay, I think the students just shy to answer the question.
Okay, no problem. Okay, the true answer is never. Never. It is not possible. It is not possible. With the number of dentists and with the treatment needs of 45 million population, it is not possible to cover all dental treatments. Never. Because the speed of progress of dental diseases in the community is much, much higher than our speed when we are doing dental treatments. This is why I told you that from community perspective, it is not possible to control oral diseases without prevention. If we do not prevention, if we just focus on treatments, we never can control oral diseases community level. Okay, just to draw your attention and change the taste. And then we can go to prevention of oral cancer for all adolescents and adults. Of course, it is not the problem with children and adolescents, but again, there are some advices. The first one is do not smoke and do not use smokeless tobacco. You can see the different names, and reduce alcohol consumption to lower levels. We should recommend our patients to do this, and increase intake of non-starchy vegetable and fruit. And regarding professional intervention, again, we have this smoking cessation consultation protocol, 3ADL, and then we should take a history of tobacco use and brief advice for tobacco users and signpost to local smoking services. And then we should ask advice and act regarding alcohol, a very brief advice. We don't have time to cover all these. Then just regarding healthier eating, you are familiar with these graphs showing that what happens when we use frequent sugar intake, when we have frequent sugar intakes, the pH drops under 5. Now here we have progression of dental caries because we have demineralization. But when we have infrequent sugar intakes, you can see the times that the pH drops is less frequent than this picture. Because of that, the frequency and amount of consumption of sugars should be reduced. And this is for all age. And we avoid sugar-containing foods and drinks at bedtime, then saliva flow is reduced and buffering capacity is lost. And the professional intervention is dietary modification. And this is the potentially cariogenic foods and drinks. I don't want to repeat these names, but you are all familiar with these things, and they are potentially cariogenic foods and drinks. This is an example of diet diary. So this is a tool that we can help our patients to have a diary for their diet and just note what they eat. And this can help them to know how many times per day they eat sugary and cariogenic foods. This is the Eat Well guide. 5 categories of foods that we should eat from all of them. And this is schematically show in which category we have some examples of the food that we have in each category. And the Eat Well guide encourages us to eat at least 5 portions of variety of fruits and vegetables, base meals on potatoes, bread, rice, pasta, or other starchy carbohydrates instead of cariogenic carbohydrates, and have some dairy alternatives and eat some beans, pulses, fish, eggs, meat, and the other things in this category. And we should choose unsaturated oils and spread and eat in small amounts, and drink 6 to 8 cups of glasses of fluid a day. And these are another sets of recommendation regarding caries, just for the same as the other one: 5 pieces portions of fruit, vegetables. Non-milk extrinsic sugars are those sugars that are cariogenic. And NMES should provide no more than 10% of total energy in the diet, or less than 60 grams per person per day. Some pictures of Iran nature. Just a couple of words about changing behavior, and this is I think I have 2 or 3 slides just remaining. So yes, we are in time. So changing, we should first thing regarding behavior change is that we should understand the process of change. Changing behavior is a lengthy and often difficult process that may involve several attempts before the new behavior is maintained. And the ability to change behavior is influenced by an array of individual, social, and environmental factors. And the provision of health information alone is unlikely to achieve sustained changes in behavior for most people. And do not expect patients to be able to change behaviors quickly or easily, just because they have been given a leaflet. This is things that we made, things that, okay, this should be in this way that I just give a leaflet, a pamphlet, some advice to the patient, and the patient should change his or her behavior. This is not true. This is not working. We should do some practices regarding behavior change. We should recognize different motivations for change. For many patients, there may be a varied set of motivations, reasons for altering their behavior, not just relating to their health. And we should avoiding disease is only one of the range of reasons for change. And we should think about clustering behaviors. Shared links, groups of behaviors such as smoking, alcohol misuse, and poor hygiene habits often cluster together in particular groups of people. So altering one behavior may be problematic if it is linked to others, if it is not linked to the others. unless careful thought is given to the underlying influences on these clusters of behaviors. These are just some points, and all of these things can be discussed in detail. There are some barriers to change and obstacles to overcome. Clinical, psychological, social, environmental factors may all be barriers to change. Highly motivated individuals with well-developed social network and supporting living environments will be more likely to succeed. And opportunities to change may be more likely at certain key points in the life course, such as leaving school, starting a new relationship, or entering retirement. So the key considerations are getting the right message across, effective communication skills like active listening, reviewing benefits of changing and past experience. We should set goals and we should monitor the progress. And these are some monuments, historical monuments in Iran. I hope all of you can sometime come to Iran and visit these monuments. Thank you for your attention. Any question or comments? I think we have 4 minutes, I think. Now it is 3 minutes. So if there is any question or comment, I'll be happy. And you can also ask your question or comments from these ways if you want. And maybe I can stop share so see the chat box if